Welcome to the Global Frailty Network Frailty Seminar Series. My name is Roberto Carlos, and I will be your moderator today. Our speakers for this webinar panel of the Frailty Seminar Series 24-25 series are Dr. Kossioni, Dr. Affoo, and myself. Before we begin, just a few housekeeping notes. Please use the WebEx chat feature to submit any questions for our speakers during the session. Okay, now let me introduce our speakers who will be joining me on today's panels to discuss oral health and frailty. Dr. Anastassia Kossioni is a professor of gerodontology and director of the section of prosthodontics at the Dental School of the National Kapodistrian University of Athens. She is honorary secretary and chair of the education committee at the European College of Gerodontology and co-chair of Gerodontology SIG at European Geriatric Medicine Society. Her research activity is mainly related to the association of oral health with general health in older adults, oral health promotion in institutional care, and gerodontology education for dentists and other healthcare professionals. Dr. Rebecca Affoo is an assistant professor at the School of Communication Sciences and Disorders, Faculty of Health at Dalhousie University, Canada. Her research activity is mainly related to speech resonance and swallowing disorders, dysphagia in older adults, dysphagia and dementia, and oral care for older people. And me, I had the pleasure of being part of the research team founders of the National Institute of Geriatrics of Mexico. My research focused on the oral health of older people, oral health-related quality of life, oral health-related expectations, oral health and its association with geriatric syndromes, and the entrustable professional activities for geriatric dentistry. All the presenters have no potential conflict of interest to report, and Dr. Kossioni, our agenda for today is an introduction on the association of oral health with frailty, chewing, swallow, thrive, the link between oral health, nutrition, and frailty, periodontitis and frailty, prevention of oral conditions by physicians and other non-dental care providers to maintain intrinsic capacity, and we will have time for questions and answers. Dr. Kossioni, please, the floor is yours.
Thank you very much, Roberto. Before starting the presentation, I would like to deeply thank Dr. Ruiz for the kind invitation and you, Roberto, for coordinating the webinar and for all the fruitful and really enjoyable discussions we have all the past months. It was really amazing to see all these different cultures, how we can all collaborate and have the optimum outcome for our patient. So this is an introduction to the Association of Oral Health with Frailty. Next, please. And these are the key points. I will start with a short definition of oral health, describe oral health status in older adults, and discuss the current evidence of the Association of Oral Health with Frailty. And this is the updated definition of oral health by WHO, launched in 2022. It's the state of the mouth, teeth, and orofacial structure that enables individual to perform essential functions such as eating, breathing, and speaking, and encompasses psychosocial dimensions such as self-confidence, well-being, and the ability to socialize and work without pain, discomfort, and embarrassment. And just by looking at this definition, you can realize the close connection of oral health with resilience and intrinsic capacity. Oral diseases are the most prevalent condition globally, and actually the current global average prevalence is 45%, so almost half of the global population have some form of oral conditions. And as you may see from the graph by WHO, the three major oral diseases, periodontal disease, dental caries, and tooth loss, increase after middle age. And there is a continuous increase for tooth loss starting from the age of 50, the peak of periodontal disease at the age of 55 to 60, and the peak of dental caries at the age of 65 to 70. Next, please. It is important to mention that age per se has no significant independent effect on most oral conditions, but most of them are associated with various environmental factors. And there are three major risk factors to oral disease. Person-related issues like illness, care dependency, frailty, a sugary diet, smoking, alcohol drink, not frequent daily oral hygiene, lack of a visit to a dental professional, and several others. It's lack of professional support, mainly associated with limited training and negative attitudes of care providers about oral health provision and promotion. And last but not least, it's the lack of effective oral health policies, including lack of integration of oral health within general health policies and limited public dental care coverage. And I'm sure that most of under this have to pay from out-of-pocket payment for having dental care. This is so common across the globe. Next, please. This is just a snapshot of some associations between oral diseases and various general conditions by the World Dental Federation, and my colleagues will further expand on those in the following presentations. Next, please. I will start this trip to the Association of Oral Health and Frailty with these Japanese studies, and that is because the largest number of studies associating oral health indicators with physical frailty have been conducted in Japan. Next, please. This is one of the most important Japanese studies, the one performed by Tanaka and colleagues, and the authors concluded that oral frailty, defined as a coexisting poor status in more than 3 of the 6 oral measures that you see on the right, was significantly associated with increased risk of physical frailty, sarcopenia, disability, and mortality. And those conditions are the number of natural teeth consistently found in most studies, chewing ability, likewise, articulatory, oral motor skill, tongue pressure, and subjective difficulties in eating and swallowing. And this is the sophisticated equipment that has been used in the Japanese studies. It requires, of course, a research center or dental premises, and it's not so easy to find beyond Japan. Next, please. A few months ago, this consensus statement has been published by the Japan Geriatric Society, the Japanese Society of Gerodontology, and the Japanese Association on Sarcopenia and Frailty. And they have associated oral frailty, including tooth loss and difficulties in eating and communicating, with physical frailty, poor dietary variety, social isolation, disability, and mortality. And instead of using this sophisticated equipment, they suggest to use this very simple to perform 5-item oral frailty checklist. And oral frailty is characterized by the presence of 2 or more of the following 5 components. How many of your natural teeth are left? Positive answer is less than 19 teeth. Do you have any difficulties eating tough foods compared with 6 months ago? Have you choked on your tea or soup recently? Do you often experience having a dry mouth? And have you had difficulty with clear pronunciation recently? Next, please. Beyond Japan, there are fewer studies associating oral health with frailty. And this is just a summary of a few of them, cross-sectional and longitudinals. There are different indicators that have been investigated compared to the ones performed by the Japanese colleagues. But the 2 indicators most often investigated and showing a strong association with frailty are number of teeth and chewing difficulties. And again, there are other factors investigated like periodontal disease, oral pain, oral problems, dental caries, or dry mouth. It is important to mention the large variability in the methodology in those studies so that comparability of findings is not easy to perform. And I close this first part of the webinar with a possible linking mechanism of oral health with frailty, which is nutritional pathway, inflammatory pathway, and psychosocial pathway that will be elaborated by my colleagues. And I now give floor to Rebecca to investigate the nutritional pathway.
Thank you so much, Anastassia. Hi, everyone. I'm Rebecca, and I'm going to expand a little bit on this potential link between oral health and frailty through a nutritional pathway. These are, oh, next slide. Thank you. These are my disclosures. So Anastassia did a wonderful job of defining oral health and explaining that it's so much more than simply being cavity-free, but it also encompasses oral function, including using our oral structures for complex tasks like eating. And I always like to start any talk that I give by reminding everyone that certainly maintaining nutrition is critical to our health, but it's also a big part of how we as humans socialize and celebrate our culture. So certainly much more than just maintaining ourselves from a health perspective. Next slide, please. And I'd like to start by explaining why oral health might influence frailty through this pathway of nutrition. So I'd like to start by talking about how we eat. Eating is composed of a number of highly complex processes, including transportation of food and fluid to the mouth using your fingers, utensils, a cup, or other methods. Saliva is secreted into the oral cavity in order to lubricate the mouth and initiate chemical digestion of starches. You then prepare the material in the oral cavity, and if you're eating solid food, then you need to mechanically break that food down or masticate it using your functional occlusal units, which are pairs of opposing teeth that are crucial for our chewing efficiency and masticatory function. And once you've broken down the food so that it's safe and manageable in terms of size, as well as it being cohesive in a ball that's mixed with saliva, we call that a bolus, you then swallow the food down in order to transport it to the stomach. Next slide, please. Thank you. So now oral structures as well as function changes as we age. And Anastassia did a lovely job of pointing out that age doesn't necessarily impact certain things. Like, for example, we shouldn't lose teeth just as a function of aging. Roberto, you can advance a little bit so the more pictures pop up on the slide here. But it's important to consider that as we age, we may experience changes to our oral health and oral function. So for example, salivary secretion does tend to reduce as a function of age, but it's also associated with polypharmacy. And as I mentioned, it's not a typical consequence of aging, but many individuals do lose teeth at some point where they may require prostheses or dentures. Additionally, there are known changes to taste with advancing age, including losses in taste perception and distortions of taste function. And there's also clear evidence of age-related reductions in tongue strength as we age. We can also see changes to swallowing function. We may see changes associated with reduced tongue control that results in losing fluid into the throat before we may be ready to swallow. And we may also see some timing changes. So it may take a little bit longer to initiate a swallow. So meaning that the food may be sitting in the throat a little bit longer before the swallow is initiated. It also may take a little bit longer to actually move food and drink through the pharynx or the throat. And we may also see changes to the actual constriction of the pharyngeal muscles, so that actually may reduce in strength. Next slide, please. An additional complication that we sometimes see in the older adult population is that they may experience what is known as rapid oral health decline. This is not necessarily a consequence of aging. Excuse me. Rapid oral health decline typically occurs in about a 2-year period, and it is a very dramatic change. In places where oral health care is not publicly funded, so where we pay out of pocket, we often see this happen after retirement when financial barriers may make it very difficult to see an oral health care provider regularly, or if there's some kind of major life transition, for example, when somebody needs to transition to long-term care and may no longer be able to independently perform oral hygiene. The evidence suggests that rapid oral health decline is a complex, multifactorial interplay of factors with a multidirectional cascade of negative health outcomes. Next slide, please. And so how do all these changes then impact our function? And as you can hopefully see in this animation, swallowing utilizes the oral and pharyngeal muscles and structures in a complex sensory motor phenomenon that allows us to transport saliva, food, and fluid from the mouth to the stomach, while simultaneously protecting our upper respiratory tract from pulmonary aspiration of the material being swallowed. Next slide, please. And I just wanted to show everyone some just additional views of what swallowing looks like. You can see a lateral radiographic view of the head and neck while somebody is swallowing. And then there's also an endoscopic view. Thank you so much, Roberto. So this is a superior view of the pharynx during swallowing. So certainly a lot going on in terms of this complex interplay of muscles and structures and function. And next slide, please, Roberto. I also wanted to highlight that even though the focus of my presentation is on the link between oral health, nutrition, and frailty, oral and pharyngeal structures are also critical for speech, which is also a complex sensory motor phenomenon and is an important component of social interaction. And the association between oral health and social interaction is not well studied, but a recent systematic review identified 7 studies that showed an association between poorer oral health and higher loneliness. So that's also something to consider in terms of our frailty pathway. Sorry, Roberto, you can go ahead. So this is just a video demonstrating just the complexity of speech in terms of using our oral structures to create speech. It's highly, highly complex and coordinated. Thank you so much. I don't think we have sound with that, but it is, if anybody wants to check out the video at the link on the screen provided, it's well worth it. Next slide, please, Roberto. Thank you so much. So when individuals experience changes or decline to oral structures, this can certainly impact oral function, and that leads to issues with speaking, eating, and swallowing. And members of our audience might be familiar with the term dysphagia, which is when someone is experiencing swallowing impairment. Next slide, please. And so dysphagia is commonly defined as reduced safety of the swallow, which results in material going in the airway when it is not supposed to, as demonstrated on the radiographic view, but it's also defined as reduced efficiency of the swallow, resulting in residual material being left behind in the throat after the swallow has been completed. Perfect. And dysphagia is most often caused by neurological or structural conditions, and it's quite prevalent in older adults in general, but it's commonly seen in specific populations, such as those with conditions that may be very common to older adults. So Anastassia did a wonderful job synthesizing the existing evidence on this topic. I apologize, I have a bit of a cough, 1 second. I'm so sorry. So she did a wonderful job synthesizing some of the evidence on this topic. And so from her evidence synthesis, it seems like, yes, there is a relationship between oral health and frailty. And she did point out that the factors that keep coming into play are this idea of number of teeth and chewing function, which really suggests that perhaps it's possible that the main pathway, sorry, go ahead and advance the slide, please. Can we advance one more? Oh, I think we missed one. Sorry, can you go back one? Thank you so much. So it's possible that the main pathway might be through nutrition. And it has long been understood that oral health and nutrition have a synergistic multidirectional relationship. Oral diseases impact functional ability to eat, as well as diet and nutritional status, but likewise, nutrition and diet can certainly affect the development and integrity of the oral cavity, as well as the progression of oral diseases, and we have data to support this. So much so, excuse me, that it is the position of the Academy of Nutrition and Dietetics that nutrition be an integral component of oral health, and the Academy supports the integration of oral health and nutrition services, as well as education and research, and collaboration between dietetic practitioners and oral healthcare professionals is recommended. The question, of course, is then how does this relationship potentially impact frailty? And so while Anastassia highlighted several findings from this evidence, I'm just going to touch on a couple. So if you could just advance, maybe hit the button twice, Roberto, just so that we have the pictures pop up. Thank you so much. So one hypothesis is that poor oral health or changes to oral health that result in oral hypofunction, so changes to function, might contribute to dysphagia that impairs a person's ability to maintain nutrition. And this may contribute to sarcopenia and eventually physical frailty. So the systematic review cited here, what is a more recent publication that identified a number of cross-sectional studies as well as one longitudinal study. And then additionally, sorry, if you could advance one. Thank you so much. Oh, and advance one more, just so that we have the animations pop up. Thank you so much. And certainly the majority of studies that have explored oral health and function in relationship to frailty have highlighted this masticatory function and number of teeth as being most important risk factors for frailty. Advance one, please. And more recent studies are continuing to identify that frailty, oral health, and nutrition are all significantly associated in older adults living in a variety of contexts, including like the community as well as in long-term care. And these factors are also associated with negative health outcomes such as functional decline and falls. Can you advance one more? Thank you. And yeah, perfect, thank you. So changes to oral health and function have this potential to cause a cascade of negative health sequelae. And this supports the idea that identifying and addressing changes to oral health and oral function, as well as enhancing nutrition, are critical components of any intervention plan. Thank you so much. However, the pathway, the nutritional pathway, may not represent the whole story. So this study was completed by Dr. Carol Bassim and colleagues at McMaster University in Canada using the Canadian Longitudinal Study on Aging data. And they explored associations between oral health, diet, and frailty. And they found that oral health and frailty were certainly significantly associated, but they found that poor diet explained only about 1% of the effect of poor oral health on frailty, which suggests that there may be additional things at play here. If you can advance one, thank you so much. And one more, so we have the boxes. Thank you so much, Roberto. And I think one important factor that we can't forget is that context matters, and factors such as the social determinants of health almost certainly play a role in this relationship between oral health and frailty. If you could advance one more. Thank you so much. So for example, we can see in this infographic that 1.8 million Canadians have difficulty chewing or masticating, and the social determinants of health significantly increase the risk that somebody will experience difficulty with mastication. Can you advance? Thank you so much. So we have evidence to suggest that eating and nutrition are certainly part of the picture, and I think very important part of the picture, but maybe not the whole picture. And so with that, I'll hand it over to Roberto to talk about another part of this picture.
Thank you so much, Rebecca. And Anastassia, it's a wonderful talk from both of you. I hope to keep the standard. This is an updated version of our 2012 model linking oral health and frailty, and this update includes sarcopenia as a modifier factor for oral function and emphasize oral function supported by the available evidence. Today, I will talk about the physiological component. The physiological or biological component of our model relies on the inflammatory response resulting from periodontal disease. Despite extensive theoretical foundations supporting this component, epidemiological evidence remains inconclusive. Some cross-sectional studies report a higher prevalence of frailty among those with periodontitis, while others report no difference in the prevalence or incidence of frailty according to the periodontal status of older adults. Let's remember that inflammation is the immune system's natural response to injury or infection. It is an essential component of the body's defense against harmful from stimuli. Therefore, oral diseases may trigger inflammatory response along with other metabolic conditions, which has been included in the causal chain for frailty, along with diet, with a diet reduced in protein and vitamins. Pretty much what Rebecca just shared with us. A poor diet may compromise the immune response, therefore triggering a low-grade inflammatory response, adding to a chronic inflammatory state and inflammation. Among the prominent risk factors for periodontal diseases are poor oral hygiene, smoking, and the lack of dental services. While its consequences are inflammatory response, gingival bleeding, and even tooth loss, a topic of increasing interest linked to periodontal disease is related to the oral microbiome and its implications for overall health. However, they also rely on the inflammatory response resulting from dysbiosis. From our model for oral health and frailty, I want to stress that oral function are also linked to quality of life. And the integrity of the oral structures, teeth, and jaw bones and mucosal tissue is essential for appropriate functioning. We know that for proper functioning. I want to close by quoting Miguel de Cervantes Saavedra, porque te hago saber, Sancho, que una boca sin muelas es como un molino sin piedra, y en mucho más se ha de estimar un diente que un diamante. For I tell thee, Sancho, a mouth without teeth is like a mill without milestone, and a tooth is much more to be prized than a diamond. Anastassia, please, the floor is yours.
Thank you very much, Roberto. And we close this webinar with some important take-home messages for non-dental care providers with instructions on what you can do to prevent oral conditions. And these are the key points. What's the role of non-dental care providers in oral health assessment and promotion, and the basics, the oral disease prevention essentials. The truth is that frail and care-dependent older people rarely visit the dentist, but instead they frequently visit physicians, nurses, physical therapists, ergotherapists, pharmacists, and other healthcare providers who are not, unfortunately, adequately trained to provide oral screening and counseling. Next, please. This is the reason why the European College of Gerodontology, Geriatric Dentistry, and the European Geriatric Medicine Society have joined forces a few years ago and signed an agreement of scientific collaboration. It created a special interest group in gerodontology within European Geriatric Medicine Society and published a series of expert opinion documents and recommendations on oral health prevention and promotion in older adults by non-dental care providers. According to those recommendations, non-dental care providers should be competent and willing to incorporate oral health interview during patient interview, provide initial oral health screening and dental referral when needed, provide oral health counseling to patient and carers, and closely collaborate with the dental professionals. And this is a typical oral health interview that should be integrated within general health interview. Simple questions that, if have an answer that is indicated on the right may mean that there is an increased risk for oral disease and further screening of the mouth is necessary or immediate referral to a dental professional. So the first question is there anything bothering you in your mouth? And the patient may respond with pain, bleeding, swelling, tooth mobility, non-healing ulcer, and various other conditions. The next question is how many natural teeth are left? If it's less than 20, again, there is an increased risk for oral disease. Other questions, do you have difficulties eating, chewing hard foods? Do you often cough or choke when you eat or drink? Do you often feel your mouth dry? Do your gums bleed on brushing, eating, or spontaneously? How often do you brush your teeth or dentures? And if it's less than once per day, there is high probability of increased prevalence of dental plaque and risk for oral disease. And the last one, did you have a dental visit in the past 12 months? A negative answer indicates a necessity to screen the mouth or refer the patient to the dental professional. Next, please. I don't think that any of you may not recognize that there is something wrong with that mouth. Teeth are missing, a lot of dental plaque, some signs of dental decay, and signs of periodontal disease. Next, please. But there is also this very simple to use oral health assessment tool that is recommended by the two societies that guide the non-dental care professional step by step what can be found in the mouth of the patient and have very clear instructions when there is a need to refer the patient to the dentist. Next, please. And we conclude with the simple oral health promotion and counseling instructions. And number one on top of the list for those who have natural teeth is daily dental hygiene, always with a fluoride toothpaste, 2 times, at least twice per day for 2 minutes. For those who have dentures, removable dentures, it's necessary to clean the dentures at least twice per day with a denture brush. It's a special brush that is shown on the second picture on the right. Next, please. Remove the dentures at night and keep them air dry to prevent diseases like denture-related stomatitis or even aspiration pneumonia for those who suffer from swallowing problems. Next, please. Adopt a healthy diet to prevent caries and erosion, and that includes limiting sugars, sticky foods, refined and processed foods, and also between meal cariogenic snacks and also acidic foods and drinks, and always rinse the mouth with a lot of water after having those acidic foods. Next, please. Control dry mouth. The best way to control is evaluate the medications list, because the main cause of dry mouth is polypharmacy or use of specific medication that have a xerostomach effect. So the answer to that would be medication dose reduction or medication replacement. And a part of that, chew sugar-free gum to increase saliva secretion, use saliva substitutes, saliva stimulants occasionally, dietary counseling, meticulous daily oral hygiene, and use of fluoride products recommended by the dentist, because dry mouth is closely associated with several conditions like dental decay, periodontal disease, and several others. And of course, stop smoking. Next, please, and limit harmful alcohol consumption, because both of them are associated with oral cancer. And last but not least, have dental checkups every 1 year if you have your natural teeth, or 2 years if the person is a dentulous. And as you may see, many of those instructions are quite the same with the ones that we provide to prevent other non-communicable diseases. Next, please. If you want to learn more about oral disease in old age, you may access this online educational resource, Oral Health in Older Adults. It was developed by Wiley in collaboration with the European College of Gerodontology. Next, please. And we lead to our conclusions. There is evidence of an association between oral health measures and frailty. Oral health markers, easy to assess by non-dental care providers, like the number of teeth, may be included in frailty assessment instruments. Appropriate oral disease preventive strategies should be implemented from early life to prevent reduced oral functionality and frailty incidence and progress. Next, please. Healthcare providers can play a key role in oral health promotion by incorporating a simple oral health interview within patient assessment, screening the mouth for oral conditions, and referring to oral health professionals when needed. Next, please. And of course, interprofessional collaborative practice is essential in frailty management. And with that, we thank you for your attention. And in the next slides, you may see our emails. You can always access us and we can discuss whatever you think as important. Thank you very much.
Thank you very much, Anastassia and Rebecca. It's a wonderful talk. Now we are open for comments and questions from the audience. Give me a minute to stop sharing my screen. The question is by Ojukwu. I'm sorry for my pronunciation. Somtushukwu. Are you able to mute yourself, please? Oh, okay. Those are asking me to silence.
I think I have one for me from Lucy Bartlett.
Yes.
So she says, with the start of publicly funded dental care in Canada, are there any studies planned or underway to evaluate the impact on frailty or functionality in seniors before versus after? And yes, this is a very exciting time in Canada. So we have the federally funded Canadian Dental Care Plan. And absolutely, so seniors, low-income seniors are going to be included in that plan. And there are plans for sure to look at outcomes of that service on a whole variety of outcomes for older adults. So very exciting. Thanks for the question.
Rebecca, can I ask you a question related to that? Because it's really, really important. Do you offer all types of dental care? I mean, even prosthodontic care?
So, yeah, so that is the question, is what is going to be included in this sort of basket of care. And so I am still unclear as to whether or not dentures are included, but I will certainly get back to you on that. It's been a difficult conversation to follow in terms of what's going to be included and what's not. So
yeah, thank you.
Roseberry asked, do fluoride dosage forms deal with oral dysbiosis in high-risk older adults?
Well, I'm not really sure if I understand that question. Fluoride protects from dental decay. And this is why it's one of the essential medicines for dentistry, according to WHO. I don't know if there are any other studies, or I'm not specialist in that, to associate fluoride with other forms of preventing oral conditions. I don't know, Roberto, if you have any idea on that.
No, it's a good question, though. I don't know, Roberto.
Well, so as far as we understand, fluoride works on the surface of the enamel and have no significant interaction with the biofilm or the oral microbiome so far. However, new species have been identified in the oral ambient, and some new studies should came out to highlight what is happening in these additional interactions. But why does how does fluoride works in the mouth is with the surface of the enamel and not with the oral microbiome. Another question by Debbie. Thank you for the webinar. It was informative. My question is, the oral health assessment tool defines a healthy score of 0 for lips and gums as pink. How can clinicians account for natural variation in pigmentation, particularly in individuals with darker skin tones, to avoid misinterpreting normal color or differences as signs of pathology, especially for new or student clinicians who may not have a lot of clinical experience to base their judgment? Thank you.
That is an excellent question. Mm-hmm.
Yeah, actually there is training. You use it after training, and training is adapted to local conditions. That's my answer. I think that there was an online resource developed by University of Iowa. I don't know if it's still online, but I think Leonardo Marchini has updated that, and perhaps that would be very easy to use and learn. But very, very good question. Our instructions on that to non-dental care professional is just for 1 hour, and then with some simple questions. It's very easy. Trust me, you can see what is wrong, even if you're not a dental professional.
Similarly, when we provide training on the OHAT here in Halifax, we do have pictures of folks who have pigmented skin and therefore have pigmented gums, so that students and new clinicians can start to identify that those things are natural variation in pigmentation and not necessarily signs of disease. So, but it is really important, and I think a huge drawback of like a major barrier in some of the tools that have been developed previously, that they haven't always accounted for differences in skin tone.
I have to say, I do remember my student years with my pathologist teachers talking about the relevance of knowing our population, and that relies on where we are trained and how familiar we are with the population we are working with. So I agree, this is relevant. It is relevant to identify natural variations, but it is, and this could be a cultural thing, or about being aware of who are you working with. If you are working with, the world today is, the global world today implies this interaction with different people with different cultural backgrounds, which force us to be familiar with these variances. But there are particular things that can be identified as pathologic. But yes, it is a challenge. Ross Perry asked, dental hygienists and dentists have shown little interest in high-risk older adults. Why will this change? Thank you for a very provocative question. What do you think? Do you think, Rebecca and Anastassia?
Well, having an experience of 30 years working in gerodontology is the European term for geriatric dentistry. I've seen a huge change. And the main reason is education, because now, at least in Europe, most dental schools and dental hygienist schools teach geriatric dentistry. So people know more about this. And this is one part. The other part is the demographic explosion. We face a new society where almost 30% would be older people. And then there is WHO with recent guidelines, particularly the ICOPI tool, the Integrated Care for Older People tool that every healthcare provider has to use in order to prevent diseases that address to older people. So I think that in the next few years, most healthcare providers, including dentists and dental hygienists, will have a more complete picture of why, what, and how. I don't know, Rebecca, if you have any other answer to that.
No, I think that was very well said. Thank you.
I would like to add, thank you, Anastassia. The history of our specialty in oral health is challenging, and we shouldn't be labeled by your history. There was a time when the procedure, the recommended procedure after the experience of dental decay was to extract the extraction of the tooth, and in case of periodontal diseases was the extraction of all the remaining tooth. This is something of the past. New knowledge is different. So I know it is challenging for a lot of people. Dental students often are prone to dental prosthesis and aesthetics specialties, but the older population is growing, and this is a global challenge. And this is not different than geriatrics, when because both of us are facing an overload of work, over demand of people requiring care. This is something that we should educate. It's not something that is stable. It's something that we have to work on daily basis. This is a shared responsibility. Thank you for the comment, Ross, Perry. And Uzma comments, very informative talk. Thank to all presenters. Ninad Bodjanovic, do you think that teledentistry can be an option in follow-up oral health in elderly, since dentists are hardly part of the multidisciplinary team everywhere? I would like to address this, which is part of the same comment I have done previously. The dynamic of oral specialties, every health specialty has been developed in a compartmentalized approach, under a compartmentalized approach. And today we have to come and work together to integrate our knowledge in favor of the patient. It doesn't matter if that is an older person or it is a newborn. The knowledge have to be integrated in order to offer the best possible perspective for each person, each patient. This is a challenge that is and a change that is ongoing, and it is moving forward. I think we all were trained under this compartmentalized perspective, and we are coming together because we are recognizing and identifying convergent topics and focusing on the patient. One of the big movements or the most recent movements from WHO is moving to the person-centered approach and leaving aside and moving away from the disease-centered approach. This person-centered approach demands from us to collaborate with each other. That is challenging. That is new for everybody. And we have to develop our skills for interprofessional collaboration. And we have to learn to communicate with each other. I think part of this talk is address this point. We have to understand each other. We have to talk similar languages, but recognize that we are moving in the same direction. Thank you for the comment, Bodjanovic.
Could I add something to answer
Sure.
a specific question by Nenad? Hi, Nenad, friend from the European Geriatric Medicine Society. I absolutely agree. Teledentistry would be a perfect tool. The problem is we don't have enough research till now about the outcomes. And we are not sure if non-dental care providers, particularly in nursing homes, where it's a huge problem, really want to get into that. So we need more studies, but I think that it will be an amazing tool in the future to come, and also it is recommended by WHO.
Madeleine Beck, thanks for the presentation. Is there only a link between oral health inflammation and frailty through periodontitis, or is there another link? One of the most most of the evidence about the association between oral health and frailty goes through through oral function, and the less evidence through the periodontitis and inflammatory fat. Most of the evidence focuses on number of teeth and chewing ability and swallowing, which was mentioned both by either Anastassia and Rebecca. Thank you for the question, Madeline. Lyubov Slasheva, thank you for an excellent presentation. Thank you so much, Lyubov. And Jorge Ruiz, I am interested in your talks on the concept of oral frailty as developed by Japanese dental researchers and based on specific objective measurements. What implications may this have for a broader concept of frailty as defined by the phenotype or deficit accumulation framework? Rebecca, Anastassia, would you like to make some comments? I would like to comment something at the end, after you.
I'm sure I know exactly what you're going to say because we have discussed about this a lot, and thank you for this. We spent many hours thinking about that. Well, the problem is that the whole Japanese oral frailty concept has not been extensively applied beyond Japan. We try now in Athens, we got the equipment by the Japanese and try to duplicate it and see if it works, if we have the similar outcome in Caucasian population. We have some primary findings, but need more because till now we don't have exactly similar findings. The implications, to my point of view, if we duplicate, if we verify, if we validate the findings at the global level, is that some of these oral measures may be included in frailty assessment tools. Perhaps this is something that we are going to see in the near future if all of us could collaborate and perform multi-center studies at a global level. That's what I think.
Yeah, I feel similarly. I feel like the concept of oral frailty, again, we have to be careful about separating oral health from health, because I think that's already happened. At least in Canada, we have this concept of like oral health is totally separate, and people, other health practitioners are hesitant to look in the mouth. And I think that can be very detrimental because we have certainly, at least in Canada, certainly we have this federal dental care plan coming, but we do certainly have barriers to care, specifically things like geographic region and finances, etc. So I think continuing to separate oral health as being separate from health, I feel is not necessarily the best way to go. I think we need to work together as an interprofessional team. I do certainly feel there's great value in identifying deficits in oral health, changes to oral function that impact overall health that we should be addressing. I also think that moving forward, we might see aspects of oral health and oral function be included in a frailty assessment, whether that's phenotype or deficit accumulation. So those are my thoughts.
Thank you, Anastassia and Rebecca. I will make my best to be short in this comment, but it's an exciting comment. The oral frailty model is really interesting. They came out with 5, 6, 8 measures to combine in a frailty phenotype style with pre-frailty and pre-oral frailty and oral frailty, that sort of diagnosis. However, I earlier mentioned my part of my perspective on the compartmentalized origin of medicine or evolution of health sciences, and promoting oral frailty is part of prevailing this compartmentalized approach. As far as I understand, and I know here, there are some of you have been around from the inception of frailty concept, and frailty is a measure, is an entity related to overall health, that relates to overall health. Therefore, talking about oral frailty is like there is oral health or oral structure are away or different from the rest of the health entity of the person. That is part of my ideas, my perspective of the concept oral frailty. One other idea is those measurements, the measurements the Japanese scientific community is using for measuring oral frailty includes sophisticated instruments, which are, again, those are objective measures, really interesting measures. However, to perform those measurements in the patients demand to, the patients require to be competent in performing those tasks. When facing the reality of older people and frail older people, you can find people with undergoing cognitive decline, experiencing different neurologic conditions which prevent them from performing as indicated. And you already know it from you can see that from the SPPV measurements. Not everybody can perform the task as required. And therefore, I can see some sort of bias in the utilization of these measurements, especially those measures, those objective measurements obtained with sophisticated, wonderful instruments. The participants have to be trained in how to use the balloon to perform the measurement of the tongue pressure, and also have to be trained on how to bite the arc for the record of the bite force. And I have made this comment to the Japanese research community very often. The bite force measurement is a force measurement, is a strength measurement. Therefore, it is susceptible to be affected by sarcopenia. That is a challenge, and this highlights the need to work together, because health is one. It's not oral health, it's overall health. It's not the digestive health, it's overall health. And for measuring, for addressing the health of the person, of the older person, we have to address the person. That's why, again, to move towards an integrative approach, to the person-centered approach. And that's, I will close with that, my comment from Dr. Ruiz. Thank you. And
Thank you.
Dr. Muna Busham, thank you for the webinar. What about the Geriatric Oral Assessment Tool Index? Can we start using this questionnaire in primary care with non-dental professionals, especially in low middle income countries? Anastassia, would you like to address this?
I think GOHI is used to measure oral health related quality of life. I'm not really sure that it records oral conditions as in the broad spectrum. And I think that it's worthwhile to spend a little more time and get instructions on OHAT. It's much more validated for use compared to GOHI. At least that's what I think when we culturally validated both of them here in Athens.
Well, I will have a contrasting opinion, because the GOHI has been used to identify the need for oral health interventions, the oral health treatment needs of certain populations. And it has been also validated for this aim. I would say this is for beginning, use it. We have to keep the work going on in order to get into a more suitable tool to use. But so far, as long as it helps you to identify the needs of the population of your patients, I think that is welcome. We can discuss about the utility later through manuscripts and comments and letters, but that is what is available today. And if that is what is available for your cultural and economic settings, that could be done. Okay, thank you. I will stop there. We are almost over time. Thank you for joining us for today's seminar. Please mark your calendars for our next session on Wednesday, May 14, 2025, featuring Dr. Julia Lowenthal from Harvard University, who will present mind-body therapies for frailty prevention. Thank you again, and we look forward to seeing you next time. Thank you, Anastassia. Thank you, Rebecca. It has been wonderful working with you. Thank you, Dr. Ruiz, for the opportunity to host this seminar and the opportunity to share our knowledge and about the topic. See you soon.